Hey everybody, we've got another specimen today. This is number 285 in our collection. And you can see that the anterior wall has already been removed, so it's already highlighting the phenotypic feature of this heart, which this is a heart with double outlet right ventricle, with both the pulmonary trunk and the aorta rising from the morphologic right ventricle with a doubly committed outlet ventricular septal defect. So now that we've gotten that out of the way and have done our little teaser, obviously the heart would have sat roughly in the chest like this. The anterior wall has been removed here, so anterior surface here towards the screen, posterior surface towards the turntable, superior head here, inferior legs here, left over here, right over here. We'll start off as we generally do, which is by trying to identify, at least externally, what is the right atrial appendage. And externally, at least this looks like it would be consistent with the right atrial appendage. It's triangular, broad-based, pyramidal in shape. So we'll go ahead and open up the heart there. And when we do that, we do find pectinate muscles spilling outside the confines of the appendage, consistent with the morphologic right atrium. Now, as we open this up more, we find the oval fossa here. And there is, in fact, a defect within the confines of the oval fossa. So there is an oval fossa atrial septal defect. And then back here, kind of tucked away, is the mouth of the coronary sinus. And you can see the Thebesian valve guarding it. My apologies, it's a little hard to open up this atrium. But once again, here is the oval fossa, and there is, in fact, a defect in it. Here is the mouth of the coronary sinus, and here is the Thebesian valve. And then we also still have the superior caval vein, at least where it attaches to the roof of the right atrium. And here is its entrance into the right atrium. When we go to the right-sided atrioventricular junction, we do find that it's guarded by a valve with 3 leaflets, 1, 2, 3. There are direct connections of this valve to the ventricular septum, consistent with the morphologic tricuspid valve. This ventricle that it opens up into does have coarse trabeculations. It does have a septomarginal trabeculation, aka a moderator band, all consistent with the morphologic right ventricle. Now, when we look at this outlet here, we do find the septomarginal trabeculation with its cranial and caudal limb, and within the Y of the septal band, aka between the cranial and the caudal limbs of the septomarginal trabeculation, there is a ventricular septal defect. This does make this an outlet defect, since it does live within the Y of the septal band. You can see that in its relation to the great vessels here, with the pulmonary trunk being here and the aorta being here, that it is in fact a doubly committed defect. And you can see clinically how shunted blood could easily make it to the pulmonary trunk or the aorta. So here we have double outlet right ventricle with a doubly committed outlet ventricular septal defect. And notice that the margins of this defect really come up to the arterial valve itself. If we come up the right ventricular outflow tract here, we find a valve that appears to have 2 leaflets, 1 and 2, that have been transected. And here is the great artery arising from that. This is, in fact, the pulmonary trunk with a 2-leaflet pulmonary valve, which is often noted in the setting of double outlet right ventricle. And then here we find the second artery that arises from the right ventricle, at least partially. It has got 3 leaflets, 1, 2, 3, with 3 sinuses. You can see a coronary artery arising from this sinus here, all consistent with the morphologic aortic valve. And here is the ascending aorta. So we do have double outlet right ventricle with a doubly committed outlet ventricular septal defect. Now we'll go to the posterior aspect of the heart here. Take a look at the other atrium. This atrium is smooth-walled. Here we can see the oval fossa, and now we can see the defect quite nicely over here from the left. Here, in fact, is the left atrial appendage. We can see that this is the entrance into the left atrial appendage. All the pectinate muscles are confined to that appendage itself, consistent with a morphologic left atrium. When we look at this left atrioventricular junction here, it's guarded by a valve that's got 2 leaflets, 1, 2, and this valve has no connections directly to the ventricular septum, consistent with a morphologic mitral valve. And so this, in fact, is the anterior leaflet, and this, in fact, is the posterior leaflet of the mitral valve. Now, when we look at this ventricle here, it's got fine crisscross trabeculations consistent with a morphologic left ventricle. Then we get into the left ventricular outflow tract here, and here we can see the interventricular communication, and we do see the aortic valve here, and we see that there is, in fact, fibrous continuity between the aortic valve and the mitral valve. There is no aortic infundibulum or subaortic conus. There will be some who will try to say then this does not fit into the spectrum of double outlet right ventricle. However, I would encourage everybody to look at the IPCCC classification, which is the ICD-11 nomenclature as well, where a group of us got together and came up with some consensus definitions and agree that the aortic infundibulum or subaortic conus is in fact a variable feature even in the setting of double outlet right ventricle. And then here is that doubly committed outlet ventricular septal defect. So a heart with double outlet right ventricle with a 2-leaflet pulmonary valve and a doubly committed outlet ventricular septal defect.